Thank you, Dr. Sandan Gopal. It's always a pleasure to be with you because it's always stimulating for all of us, and I think it's nice to see so many people coming here in spite of early morning and after a gala dinner night before. So how do we deal with the management of under or over correction? They say in Strabismus there are only two problems, either it is under corrected or it's over corrected. So we want optimal correction. Complications are there in Strabismus surgery, and they can be errors that of omission, that means you may have done a misdiagnosis or you may have done a faulty planning. It's like losing your passport because of your misplacement. Or you can have an error of commission that you made a mistake in choosing the profession. Now, how can this magic fail? You want to demonstrate great magic and you end up having your head down. The problems which can be there. Now look at this picture. What do you think? There is a squint there in this picture. Yes? How many people can diagnose there is a squint? Just raise your hand. Okay. So there are people I see 50% of people feel that there is a squint. Is it correct?
No.
Appearances can be deceptive. Don't go by appearances in life as well as in studies. So you have to be aware of this first peril that can be an improper diagnosis, a pseudostrabismus. It can happen in the form of pseudo-esotropia, pseudo-exotropia, or even the pseudo-vertical deviations. Whenever we deal with children who have mongoloid eyes, then they appear to have a squint of eso, much more so when they look on the side gazes. As you can see the picture on the side gaze, the eye appears to have an esotropia as well as an inferior oblique overaction. This is not correct because the eyes are symmetrically deviating, and symmetrically you can see the Hirschberg's reflex in each eye in this primary position. The other picture, second one, also you see, do you have a pointer here, sir? In the other picture also you see a pseudo-esotropia, and why is that there here? The eyes are appearing to, this in fact I'll tell you, when she walked in my clinic, even I initially thought this is a squint. If you just see this part, it will appear like a squint, but when I did a cover test, I realized I am wrong. And thank God I looked for it, because it is euroblephron, large palpebral apertures. In Hindi we say mrugnaini, deer-eyed, no? Beautiful eyes, but sometimes can be creating a problem. Or you can have pseudo-exotropias when the eyes are appearing because of a positive angle kappa. Now you see the pupil centering is not there. This is appearing much more nasally placed. Or you can have a telecanthus along with a hypertelorism. Telecanthus causes pseudo-esotropia, but hypertelorism causes a pseudo-exotropia. That means the orbits are having more space or IPD is more. So simple cover test is what we are basically prescribing you to do, and it's not difficult to do. Second is glasses we were talking about. You have checked for the cycloplegic correction and you have to give the proper full correction. Then only cycloplegic refraction with proper prescription is essential. Otherwise again you will have problems after surgery. Fixation devices. In children, if you examine with the torchlight, accommodation is not going to be excited. You will miss the accommodative esotropias altogether, and you will have problems of recurrence coming in again and again. Then again, we have to see that this target, you see the child is looking straight. When he looks at the target, the ESO is coming in with the same glasses. That means there is a bifocal required in this case. So you have to take care of that also. Then when we look in up and down gazes, there can be a deviation. Now eyes appear straight here, down there is ESO, up there is an exo. In the same child, look, just position has changed it. So you have to be careful in which position you measured and what is happening in the other gazes. So if you know properly, you diagnose it and you have corrected the inferior obliques, no horizontal surgeries, the eyes are straightened in down gaze, primary position, up gaze, and all the gazes. So that is what you need to do. Asymmetric inferior oblique overaction can be there, and you can check for these. And A and V patterns will be dealt with in more detail by my friend Dr. Gopal. So A pattern similarly, you may have to check for. Then near distance also it can be different. The problem with strabismus is that it is a three-dimensional world we are living in, and changes keep occurring. For near you find there is an exo, but for distance it is much more. And it is not that it is intermittent breaking, because when you give a Spielmann occluder, for near it is not changing much, but for distance it is happening. So mind you, this is a true divergence axis. Similarly, there can be a convergence insufficiency. For near, the exo is much more here, and this is for distance. See that? So people do not have a convergence, tonic convergence weak, and so they have this problem. So there can be a near distance problem. and there can be DVDs, infraoblique overactions. So all these diagnoses you have to make it and then correct the proper thing. Torsion is another thing which you should not forget when you are measuring the deviations. There can be problems like dysostosis or plagiocephaly, which can give rise to a deviation which is going to be managed. You see here, this is a three-dimensional reconstruction of the skull, and this is a plagiocephaly, early fusion here, and this causes a trochlea to be more posteriorly placed, and this will cause a desagittalization. This superior oblique is matched with the inferior oblique, but here the superior oblique is going to be weak. So it is a normal superior oblique but underacting. So if you are going to examine such cases, you will correct it. Similarly, frontal bossing. Now this is the reverse of what you saw earlier. This superior oblique is going to be overacting because of a frontally placed. So this is an sagittalized superior oblique. Then proper diagnosis, DRS versus LR palsy. You did not make this diagnosis, did a resection, you have landed into deep soup. So be aware of it. Always measure the deviations with prism bars and not by just Hirschberg's test. You have to ensure that you do not stack the prisms one over the other, because the power of this will not be the same as this. So you need to measure them with split prisms over the two eyes. When you have glasses, then you have to check that these glasses are also having an induced prismatic effect whenever you have an ESO or exo deviation. If proper centration is there, the glasses do not have any prismatic effect. But in cases of deviation, they will always be having a decentration for one of the eyes. So that will induce the prism, remember that. So you have to take no chances if you want to win the match, okay? And you want to see the binocular status, and the goal has to be finally that we will correct the squint sight and restore the stereopsis. The 3D vision has to be maintained. We want the children of our future to have normal 3D perception, and that we have to check this stereopsis both for distance and for near. And you can also check it by simple Lang's pencil test. Right? How much surgery should I do? The tables are there, but as we say, there is a statutory warning. You use it at your own discretion, and you have to change it as per your own surgical changes that you are dealing with. Eyes in children are smaller, so you have to undercorrect the surgery in cases of children, otherwise you will have a problem. Correct planning. Now, strabismus fixus cases, you may have these muscles may be dispositioned. There is a dystopia of the pulleys, and so the superior rectus and the inferior rectus both are nasalized. It will cause an esotropia like in this case. So if you have this doubt, and the FDT can be done, and you can check for it, FDT is free, and it may be a displaced superior and the inferior rectus. So intraoperatively, again, you can manage the problems: wrong eye, wrong muscle, wrong surgery, or hemorrhages and perforation. These can be avoided. Remember, you have to measure the things from the proper position. Well, I think skip these because you are all supposedly strabismologists and doing surgery, but you have to be just aware of all these problems. Now coming to the undercorrection and overcorrection, what happens? If there is an hyperope, let's say more than 5 diopters, there can be a problem of undercorrection because these are smaller eyeballs. Remember, we talked about infancy having small eyeballs. Even hypermetropes, the eyeballs are smaller. Axial length is smaller, so the effectivity of a surgery is more. So you can have a problem. Remember, you can have an overcorrection for the same measurement if you didn't take care of this hypermetropia. It's not only correction. Remember, it is also the size of the eyeball which is smaller and gives you more effect. Small globes, more surgical effect. Astigmatism, if there is a high cylinder, I have generally seen, you end up having overcorrections in these cases. Young children, infants, of course, we know that near distance disparity, again there can be a problem, and missed AV patterns and amblyopia are the causes for these problems. How do we correct the exotropia which is occurring secondarily? Now, if there is a small XT, for small time, you want to just watch for 1 or 2 months after the surgery, you do give over minus glasses. This is what we were talking about. You can give over minus glasses. This will induce the accommodative effort and keep the exo in check. For the time, you can follow up and see what is happening in a 1 or 2 months period. If it is worsening, you will have to operate. If it is maintained, then you can gradually think of prismatic correction. Check for adduction deficit if there is an MR slip. Now, if you find the adduction is deficit, then there can be a slipped MR. So on the first post-op day, if you find you got a sudden overcorrection, adduction is deficit, then you have to keep this in mind and go back immediately. This is an emergency, should be handled within a week. If the LR is tight, then again there can be over resection done, and this is what may be there. near distance disparity. Sometimes you get post-operatively, you got a near distance disparity. Now what is this near distance disparity? You measure the case, for distance you find that the deviation is so much, for near it is different. Why this is happening? But then the planning becomes a problem. What do I do? Because if I do a LR, MR or any surgery, it will have the same effect both for near and distance. It may correct one and overcorrect the other, or correct one and the undercorrect the other. So in these cases, we need to see. Now this girl who came to me, she had a near 4 prism diopter basin. For distance, she has a 40 prism diopters basin. Now if I correct any one angle, I am going to be in trouble for the other. No, that is a 36 prism difference. So what I did was a technique called resection recession of the same muscle. Not same eye, resection recession of the same muscle. So the LR resect 3.5 and recess by 7 mm, and we got post-op a 2 prism diopter base out and distance 10 prism diopter base in. See this. So you still have a little disparity which is acceptable, because now this is fusible and this is within the limits of our binocularity. So you have to keep on judging what is to be done and what to do. This is the mechanism how, just like Farden operation, this resection recession is going to work by giving a less effect for more weakening for distance and less weakening for near. So it's a near distance disparity can be corrected by this procedure, especially for lateral rectus. If you have a residual XT, look for the fullness of the abduction. If you find it is full abduction and still there is a residual XT, look for the tightness on FDT. If there is a divergence excess type, one may do more of the LR recession. If there is an adduction limitation or convergence insufficiency type, you may require to advance your MR. So you will judge post-operatively what is there and you will do this technique. If there is a secondary ET, now in children we don't want ET to happen. So that is why many people say don't operate in children less than 4 years of age unless there is a constant exotropia. Intermittent exotropias, you should defer the surgery 4 years because the eyeballs are small. You may easily have a much more overcorrection. So you will have a problem because esotropias are less forgiving and they will immediately cause amblyopia. Exotropias are forgiving. So use base out prisms if ET is over 2 weeks, and then you might have to take care of the, if full correction has been given, hyperopic correction needs to be taken care of again. Maybe you missed, so you had an ET. Abduction limitation or asymmetry, slipped LR should be looked for, and again look for the near distance disparity if there is a divergence excess or there is an LR rejection. So this is how you will tackle these different situations. When you are in trouble, adjustable strabismus surgery is a very helpful tool. So if you are in doubt, you can do an adjustable procedure and you can adjust it on the table. So people who have binocular vision, diplopia, they are demanding. They will sit on your head if they have a post-operative diplopia. So adjustable surgery is a good tool in these cases, and these are just showing you the techniques for that. A bow tie knot or a slip knot technique can be used on the adjustment day. So this is what I would like to stop my talk here. I thank you for pleasant listening, and if there are any questions, I will be happy to answer.